So I'm Dr. Sharonne. I've met many of you in the room, and I just want to thank the folks who made this, who invited me, and who made this happen, particularly the planning team of the walk and reunion, Ellen Robin and her team, and Bob Alico, who, without starting this organization, we wouldn't be able to come together like this, both to learn, raise money for research, to share with each other, because as Bob and I were saying, I remember saying, I thought it was really funny that first Chicago walk, they called it a reunion. So nobody had ever met anyone. So, but by the end of that weekend, everybody had something in common, not necessarily something that they wanted to have in common. So what I'd like to do today, in a way that I hope that if you have questions as I talk, you can raise your hand, and I will leave some time to share kind of where we've come from, as well as what we're working on right now, and then take your questions. And I obviously can't take your own personal care questions, but questions that are broadly about SCAD, I'm happy to take. Because sometimes your questions help spark other research ideas for us. For those of you who haven't, I'll have you hold up so we've got some Mayo Clinic things, and particularly the one on her, right, no, that one's the black one at the back. So we put that's, if you got one last year, this has not changed, we didn't make a new one, but it gives you an idea of what, Stan is over here. It gives you an idea of who our team is, what we're working on, and then there are actually copyrighted articles that are from medical journals that we have authored, including the 2018 American Heart Association census statement, and so those are yours. We actually have to pay for that to be reprinted, so you should not, you get in copyright or get us in copyright to start making mass market copies. But that's for you, and I'm not taking any of that home, so there's some SCAD brochures over there. There are patient ed brochures, and they have some simple pictures, and I encourage people, because sometimes a picture tells 1,000 words, and particularly for family members who are still wondering, what N doesn't happen to be one. So I'm going to, for those of you who've heard me speak before, I don't like podiums, but I did bring a remote clicker. There wasn't one here, so I shall have to stay close. Wanted to have some contact. Several of you, and I'll start with that, who may have been part of the research study a while ago. We are now moving toward trying to do more of our follow-up surveys and others via electronically. When we started the study, actually our IRB would not allow us to contact patients like that, so we don't have a lot of your email addresses. And so if you haven't gotten communication from us in the past year, that probably means either you've got a bad email address or we don't have one. And so if you send to mayoscad@mayo.edu, it's in the book. Those would be the contact people that could help. And if you were using Jill Boyan's email as your main contact, she's left Mayo. She's with family in Mississippi, midlife, change of life. And we realized that she was supposed to be mainly using the Mayo SCAD, and a lot of them, the emails were going to her personal address. So if you sent something to her in the past 3 or 4 months, it is sitting in an email box that we can't access. So maybe go look back and resend them to the Mayo SCAD. Rachel Giroux is a rock star. She's young, straight out of college, and is doing a great job as our study coordinator. And she's hoping to go to medical school, so we may have her just for a couple of years. So we want to make sure we use the group's email address. So that would just be one thing. And for anybody who is online, FaceTime, if you have been waiting for a response from Jill, this is why. She was at the, she was able to come to the Chicago Walk and sort of say goodbye to everyone, but she had family in Mississippi and decided this, and her kids were grown, so that's what she's doing. So I just wanted to make the point that, as you can probably tell, SCAD has become very much a part of my life and a part of many of us at Mayo Clinic. We've been coming to these walks. Many of you have come to Mayo either as patients or to tour around and to see what's going on. I revisited this year, as you can see. And we are very appreciative of the money that is raised at these types of events. These are trust money. Running blood tests and doing echoes and all of those things, and paying a Jill or our nurse abstract. So where did we come? So we started out back before I was a SCAD patient. I'm not that old, but right up until when I went to cardiology school, clearly we were told that SCAD was rare, extremely rare, as a cardiology fellow. I mean, there's a paragraph in a cardiology textbook about it. It basically said, you know, it happens to women after pregnancy, and it's highly fatal, and that's pretty much all we learned about it. And when I say survival was reportable, that means that the case studies that somebody actually got through SCAD were the ones that were being covered. And they were mainly diagnosing them in the pericardium. So I'm going to show you how that's changed. It's not now 60, 70% pericardium. It's different because we are now diagnosing more of non-pericardium. And 70% were women. I think we were really missing the women as well. That's a whole other story. So what's changed? Well, patients who are driving change, whether it's with their individual physicians or to lift up research to places like Stanford and Mayo and Mass General and others who are doing the research. We're working together, and I think that's really important for you to know that Mayo is a part of, if you look at that scientific statement from the American Heart Association, although 4 of those many authors were from Mayo, we were working with folks from Canada and England and all over the country. And I think that's really important. So some people ask, and it's a legitimate question, well, who's doing the best research? I would argue that ours is pretty darn good, but we would not, it can't be isolation. You have to have people who have the capability or the skills or the patient population who can maybe look at the same thing a little bit differently, or who can look at something that we can't. And I think that's where, and then what we do at scientific meetings is we compare our findings. Sometimes in a poster or a presentation, but sometimes just, hey, I'm noticing this. And they say, I'm noticing that too. And then we can both explore that hypothesis. So I think it's really important that we are looking with others. So what we're really doing now, what research is trying to find answers to unanswered questions. So this was our very first poster. And posters, for those of you who don't know that, it sounds like kind of geeky or like, what do you feel about a poster? When you are first doing research of any kind, the first thing you do is you submit an abstract to a national meeting. And if it gets accepted, it's got scientific merit. Then you create a poster that something looks like this. And there's a poster session where people walk by and they read your poster and ask you questions and stand in front of the poster. It's often a way for you to look at other people's posters, obviously, and learn what they're doing. But also you get valuable insight from people that read your poster and they say, why did you do this? Why didn't you do this? And this was where we basically took those first 12 patients and showed that we could do this type of research with a virtual registry. So that was the first. What is SCAD? Well, as most of you know here, but again, picture worth 1,000 words. So normal artery up in the top, a little bit of a flap, and then when SCAD happens, you can get partial obstruction because you've got a flap, or you can get completely occluding. What is most common is what we're calling an intramural hematoma. And that's what we were missing. So an intramural hematoma is more like a bruise over there. So there's no flap. It's just a bleed between the 2 layers of the artery. So that can look like on an angiogram, which is how we diagnose. It can look like nothing. It can look normal. It's mistaken for normal. It doesn't really look normal. It can look like coronary vasospasm. It can look like plaque if you're not thinking about it. And so what we have learned now that prior to about 2011, we were missing about 80% of SCADs, because about 80% don't have a flap. I think that's really important. So most cardiologists who were trained before 2009, 2010 were told to look for a flap when they were doing it, which is why so many were missed. And they were missed at Mayo Clinic because we didn't know that was what it was. So thinking about what are some of the causes, I had a couple of people come up to me at the walk and said they were really upset because no one told them what caused it. And I guess I would say that for the most part, we don't know what causes SCAD, and that's part of the potential for research. But what have we found? So there is a heightened risk around pregnancy, last week or two of pregnancy and the first month after pregnancy. Obviously, millions and millions of women have babies that don't have SCAD, so there's got to be something else. We do think it's probably the hormonal fluxes that are associated with pregnancy, not the labor and delivery itself. I had initially thought that maybe, like I said, but I've had several people who had planned C-sections or others where they had no extensive, so it's probably all the hormones that go on, and there's some reasons that that might be the case. So it is predominantly women, so you know that hormones probably play in some way, or just being a woman. There are some associated factors that may or may not be causal, so coronary vasospasm, migraine headaches, and other associated features that we are finding that more women have than women have with SCAD. And very rarely, and I would make that green bubble even smaller because probably less than 5% of people have an actual collagen or a genetic abnormality that we can test for. And that used to be thought that, oh, that's the main cause of it, and actually when you do cause it. So I think it's still reasonable to look for that, particularly in people who have a family history of early unexplained death or heart attack or stroke, but the yield is low. And because this is a rapidly evolving science, and the price is going down, and these tests are very costly, what I will often tell people is this is not time sensitive, and that maybe waiting another couple of years where their insurance may cover it at that point, or it might be so inexpensive they're willing to pay for it out of pocket. Don't break the bank on genetic testing because the yield is low. Some people would say, well, it's only 5%, why should I get it at all? And what I would say is, if you're in the 5%, it does have implications for first-degree relatives, so siblings and your children. And then the biggie is that in 2010-11, both the Vancouver group and the Mayo group discovered that fibromuscular dysplasia was associated with SCAD. And the reason it's such a strong finding is they found our FMD patients are having more SCAD, and we said our SCAD patients are having FMD. So coming at it at opposite directions, which then allows you to sort of say that probably is a real thing. So fibromuscular dysplasia is an abnormality of the blood vessels, of the middle layer of the blood vessels, the muscle layer. Pam Mace, who is at the walk today, is the executive director for the Fibromuscular Dysplasia of America, FMD. It's a Society of America. And she has FMD, hasn't had SCAD, but we're working together with FMD folks a lot these days. We actually invite them to our meetings, and they invite us to their meetings because the overlap is significant. And so FMD is also associated with high blood pressure, migraines, with dissections and aneurysms. So there is an overlap syndrome there. I'll go back just a bit. So we have these underlying causes. Remember, we started, everyone wants to know what was the cause, because if you know what the cause, maybe you could prevent it, right? Or at least you'd know, and in your head that feels better. Kind of what most SCADs, and we realize some people are just having a normal day and it's really no different than other days. So we know that not every person is at a perfect storm, but many, many patients with SCAD have had either a physical trigger, like a very high intensity, or just taken up exercising. They have an emotional stress, or the pregnancy, or something else. So it may be a perfect storm. And again, that's not every, but probably at least 25% and upwards of 40% have some type of trigger, but they also have something else. So here's some of the collaborations we have and some of the team. All right, we're going to see if the sound works. This is about a 9-minute video. We put it together. It will go up on our website in the next couple of weeks. Literally, you're the first people outside of Mayo people that have seen it, if it plays.
We became aware of SCAD years ago. We all knew it existed. It was felt to be as rare as hen's teeth, almost never seen in a lifetime.
Spontaneous coronary artery dissection, or SCAD, is a type of heart attack. It's when the lining of the heart artery splits and causes a reduction in blood flow to the heart muscle, causing a heart attack. SCAD is the most common cause of heart attack of women under 50. It is the most common cause of heart attack among women who are pregnant or have recently given birth.
The symptoms related to that are very consistent with what we consider symptoms of a heart attack. Chest pressure or chest pain, nausea, vomiting, sweating, those sorts of symptoms. Patients do tend to be quite healthy. In many ways are living a healthy life. Many are actually athletic, and I've even had some tell me they were the healthiest they've ever been when they had their SCAD.
If you are a young woman who's in the prime of life and you come in with chest pain, it may be that the ER doc doesn't immediately think, oh, I wonder if she's having a heart attack. And there's some pretty straightforward and accurate tests for a heart attack. Troponin, which is a blood test, and an ECG.
We're better at recognizing it and diagnosing it. And that has come from a collaborative effort in regards to awareness, patient advocacy, but also better abilities to diagnose it on the coronary angiogram.
Determination of SCAD is usually made in the catheter lab. Sometimes we'll need to do additional studies to figure out whether it's a cholesterol heart attack or a SCAD, and that involves putting a small camera, if you will, inside the vessel and looking at the vessel from the inside. So it's really important to recognize the difference between these two causes of a heart attack because the treatment may be very different.
When we make that diagnosis of SCAD, we take a step back and think about the strategy. We don't just go barging in and trying to put stents and balloons in. We look at the artery, we look at the flow, we look at the patient and see how he or she is doing, and then we make a decision there in the cath lab. After a SCAD heart attack, especially if we don't put a balloon or stent in, and we're going to let nature take its course and hope that it heals.
Many patients do well headed forward. At least in the small studies we've had so far, when you compare people who've had SCAD to those who have heart attack from other causes, those who have SCAD tend to do better in regards to living long and so forth. I think that's incredibly encouraging. If you see a SCAD and it is not impairing blood flow to the heart, you can let it be and observe the patient and let the body attempt to heal itself.
More often than not in SCAD, we tend not to put in a stent if there's already some blood flow through the vessel, but we do keep people in the hospital for longer than a standard heart attack. And the reason is that there is a risk that the narrowing can get worse over the first few days after presentation.
We dismiss the patient to home, and within a week or two, we encourage them to start cardiac rehabilitation. It is to get people moving again. It's also to give them the confidence in their body again.
We know from some studies that after SCAD, patients can experience anxiety, depression, and even some can be post-traumatic stress disorder.
Without follow-up and good treatment and addressing these mental health issues, you may have really somebody who takes a lot longer to heal and feel well than they should. One of the things that we knew even a couple of decades ago about SCAD is it did appear to be cause of a heart attack immediately after birth or during pregnancy. We do recommend that a patient after she has had SCAD not get pregnant.
For some of our younger women, that is a huge concern. And some patients, despite knowing risks, do decide to go ahead with a pregnancy, in which case we then develop a team of maternal fetal medicine physicians, cardiology, and anesthesiology to come up with a roadmap of how to make that pregnancy as safe as possible.
It isn't a lot of medical therapy. Generally, we have them on a beta blocker for at least a year. Beyond that, there isn't a SCAD medication program.
We're learning so much about it, about the cause, potential prevention, treatment, and management. I think there's every prospect for improved therapies because of the research that's being undertaken worldwide.
What we're looking for is a small, subtle abnormality in the genetic code that is linked to the coronary artery dissection.
Research is still in its infancy for SCAD. What we need to be doing is being able to find that foundational, what is the underlying cause, whether it's genetic, biological, or environmental trigger.
The premise of our research is that genetics must play some role in susceptibility to a SCAD event. So our research study started in 2011 when we enrolled our first patient with SCAD. What we found is that in a small percentage of people with SCAD, they had a genetic defect or misspelling of a gene that makes a protein in coronary arteries. I think we will find that there will be many different genetic causes for SCAD, but there may be common threads that tie these genes together, and it may suggest a drug that might be used to prevent SCAD from occurring.
There's still little information about anatomy and understanding of how the heart functions, and there are novel techniques non-invasively to try to assess those things, but also possibly develop tools that will be helpful clinically for detecting risk among patients.
We know that anywhere from 50 to 80% of patients who have SCAD also have fibromuscular dysplasia. This is an abnormality of the middle layer of the arteries. Have we reached the point that we can say FMD causes SCAD? In a scientific and the pure scientific rigor, no, but they're definitely associated.
We know that SCAD can occur again in 10 to 20% of patients. And one of the focuses of the research is to better understand, one, how many people are at risk for additional SCAD, and two, what puts them at risk. And finally, three, how can we prevent or reduce that risk headed forward for patients?
What fuels me is the patients, the advocates, and the SCAD angels who are the wind beneath my wings.
I don't think I can stress highly enough how grateful we are to the patients who've experienced SCAD, who have volunteered their medical information, their blood, their time, and their bodies for scanning to enable us to learn about this condition. There is no question that the field has moved forward rapidly because of their involvement.
So, that's the first time I've watched it with more than me on a little computer. So, and I was always looking for the misspellings. So I liked it. I feel like it really reflects my colleagues and my commitment to you and to continue to work for it. And so the people who are featured are really our core group. So Dr. Marisha Tweet, who started working on this when she was still a medicine resident, Dr. Rajiv Galati, who has probably reviewed, well, I can confidently say he's read more SCAD angiograms than anybody in the world, along with Dr. Best, who wasn't featured, and then Dr. Tim Olson, who has really refocused his research work on, he still does some hypoplastic left heart, which is a general heart disease, but he's mainly doing SCAD now. So, you know, out of that and how we teach other people is through publishing our work. So it's the posters, and then it's getting a manuscript in a peer-reviewed journal. So that continues to be that. And I often get questions from patients and from research participants. So what's new and what's different? And I will just say that often it's really incremental. I wish that there was a eureka of discovery. You know, some very long deceased colleagues of mine at Mayo Clinic won a Nobel Prize for discovering cortisone, which has saved many lives. Mayo Clinic gave it away, which some people ruined the day because we probably. But I don't think, right? I mean, what the royalties from prednisone for the past 80 years. That's just Mayo Clinic, honestly. But I will say that it is probably unlikely we're going to have a eureka-type moment for this. It's going to continue to be incremental knowledge, like we should use this medication or not. We should do this test or not. And that's how most science is. It is not a eureka moment. I do like to pause at this particular slide because we had so many patients who had reported to us that their chest pain, that they didn't have chest pain except the day before their period or the day their period started. And they said, my doctor's told me he's never heard of it, it's probably not cardiac. And I said, we hear about it all the time. And so we decided to do a study. Some of you in this room may have gotten a follow-up questionnaire where we asked about it because I wanted every one of them who said my doctor's never heard of it to be able to point to this paper and say, it's real, it's a thing. So this is you have a copy of that if you picked up the booklet, which is the scientific statement. So just some education. So whenever we do a scientific statement, that is a statement, which means it's a consensus statement. That means that everyone who is an author had to agree to the whole content. So there's some places where we agreed to disagree, and that's what is written in there because there was not enough evidence. My goal is that we will someday reach the level where we have enough evidence to do a guideline. Because a guideline is where you actually have evidence from research studies that you cite, and then that can change practice. So this is the first step toward that. So we continue to do these studies. I'm going to talk a little bit more about this study, which was an international collaboration with Dr. Olson as lead, and he was a co-first author. And then, circling back to that networking that we started at the beginning. I think what's also been gratifying is, somebody was telling me that it seemed like everybody seemed to know about SCAD, that they were asked about. Now that's not universal, but I do think certain hospitals who have either had a patient or who really are a continuous learning organization, who they had a patient and they made sure that all the nurses and all the doctors and all the people in the ED made sure that they were going to be ready for the next patient. And that's really what we're hoping to do, is help other organizations, hospitals, and individual practices be aware that young women can have heart attacks. They often present with the exact symptoms of a heart attack. It's just that they don't think about it when they go in there. And neither do the women. So Women's Health, there was a little blurb that this is on the News Center for the American College of Cardiology. There were 2 whole SCAD sessions. There's at least 2 at the March meeting that are put together. It's SCAD experts from all over. This was all about SCAD and time. This is the little plaque that we have at Mayo Clinic. This was from the last, where we had survivors come down and present us our check. And Danielle Denline, who some of you have heard about, she had SCAD a number of years ago, and this was some art she did this year and shared with me and said I could share with you. She has her heart a little strained. So, update about the registry. I said it's almost 1,200, and we're getting very close. The basic part of the registry is the questionnaires that you filled out. We look at your imaging, particularly the coronary angiograms and any imaging that might have looked at the other blood vessels, or look at whatever you send. We also ask for a SCAD narrative, and we're missing a lot of those. So if any of you who sent in your packet didn't write about your story, we actually have a medical student who's very interested. She was an English major, and she's very interested in looking at those SCAD narratives or pulling out some of those stories, because I think that your stories bring this alive to other people who are taking care of it. So anybody who doesn't recall if they wrote a SCAD narrative or wants to send a different one in, we are happy to take that. I always like to, because I get questions about, I didn't hear back. Well, this is a registry, so you will hear back hopefully that we got your materials, but the way we report out the results of the registry are by using the things that you send and doing the medical publications. If there were ever a finding that had enough impact that we would contact you, we would contact you and reach out. So if we found a gene and you happen to have that gene that would make a difference in your treatment, that would be when we would reach out to you. But beyond that, this is not a clinical trial where you're going to be randomized to 2 different treatments. And so I think just understanding that this is a registry, which has some real strengths, but also has some weaknesses in, because we aren't really testing a hypothesis, right? We're not saying do beta blockers, are they beneficial or not? That is a study I think is very important for us to do, and we're actually talking with some collaborators, because that would probably take more than just Mayo Clinic to be able to do that. I think there remains the issue that some of you I know have faced, and that I alluded to in the video, is we're still stuck a little bit that you don't look like a heart patient. And so it has nothing to do with SCAD. It's the fact that there isn't even a suspicion when you go in with your symptoms that you are having a heart issue at all. I know our emergency department does. I'm not saying they're perfect, but they actually have protocols, so if you can deviate from protocol, but if somebody says anything that has any of the parts of potential heart attack symptoms, they're going to get tested for a heart attack. And I know that's not necessarily true in some places. They're not hard and fast. It's actually up to the doctor or the nurse to make a decision. No, they don't really need that. And I think encouraging protocols for heart attacks, not necessarily for SCAD, because part of the problem is just not recognizing that this patient is having a heart issue at all. So there's more of the contact information again. Didn't get it first time. This is just the number of publications about SCAD over the past decade, well, several decades. And you can see that the last decade that we've been involved in our registry has been very good. It's not just publications from us, but I think it's going to continue in that way because there's a strong interest. That's just 2019 so far.
Are these publications, excuse me, that all of us are able to view some kind of the SCAD website when they become available?
Well, these are not all Mayo publications. These are all publications about SCAD. So many of these are published in journals that require a subscription or a pay to the article, by the article. Some are open access. Your doctors probably, for many of these, if they have a hospital library, they may be able to get it for free. If it is a Mayo study, we often put it on our Facebook page. And if it's open access, sometimes it's closed access for a period of time, 3 months or a year, and then you can access it. So that's a great question, because a lot of these are not, and if you click through and try to read the article, it says, pull out your credit card and pay $35. But also often your doctor can download it for free because of his or her institutional or personal subscription.
So we can know when there's new articles?
Well, if there's a new Mayo article, we actually put it, even if we can't, by copyright laws, we don't necessarily, we can't maybe provide it free. Sometimes I cheat just a little bit and put JPEG, so and then I get complaints, it's blurry, and I'm like, I'm going to get in trouble if you keep arguing. It's a Mayo Clinic Facebook page, and they're going to come after me. But so for Mayo ones, but no, we don't necessarily do that. The other place that you can go and click through is for Mayo publications on that website, the www.mayo.edu/research/SCAD, which is where we've got stuff for patients, stuff for doctors. There's a PubMed, you can click on it on publications, and it has all of our 50 or so things. And you can click through and find out if you can get it for free. You can at least read the abstract, which sometimes is enough, right? You just want to know the major findings. You don't need to look at every single word of a genetics article. So I'm just going to tell you about a few of the things that we have published in the past year or so. So one of the, it was alluded to, is we realized that people who are treated with SCAD by not getting a stent early on, about 10% of them, that SCAD would extend a little bit early and kind of be, oh, now we have to put a stent. So if we can avoid it, but it doesn't mean that that first day we should just send the patient home. So in the AHA consensus, we actually say people should stay in the hospital if they don't get a stent 3 to 5 days to watch. So they're in the hospital if they have recurrent symptoms. We also wanted to see, okay, who are the type of people who are more likely to have that early complication? Now, so there's so this is an intramural hematoma. So right, it's a bruise, it gets a bit bigger, and that artery, this is where the blood would go, gets narrower and narrower. So if that were to extend over a day or two, the patient would probably have more chest pain, and it might be that we would want to go in and do more angiogram. Actually, if individuals then develop a flap, it releases the pressure, and actually often, so they get more chest pain and then it resolves and they do fine. What we found is if they first have a flap, remember that's only 20%, they actually are much less likely to have that recurrent chest pain. So maybe they've already, when they got the flap, they've already released that pressure. So that's a finding that we did. Yep.
So if it's just a hematoma, would pain be intermittent or would it be constant as
Yeah,
it
it could
gets?
either. So the question is, for those who might not hear you on the, is if it's a hematoma, would the pain be constant or would it be intermittent? And the answer is it could be either. So if this closed off altogether, so this is a very irritated artery, so you can imagine it might spasm down on top of it even if the blood isn't completely blocked. That said, there's probably pain, we believe there is pain in the actual splitting of the artery. We know that aortic dissection, which is the dissection of the main artery that comes out of the heart, is incredibly painful. And there's no reason to, so we've taken people back to the cath lab who were having worse pain, and their artery actually looked better. There's no blockage. And so we think that some of the pain isn't due to blocked blood flow, it may actually be to healing or the tearing of the artery. So, so we often have to take people back to the cath lab if they have more chest pain, but we actually often will find their artery is already healing, it's looking better, so we think it may be more related to the tear. So the pain related to SCAD can be severe and persistent. It also can be intermittent, as it can be for other types of heart attacks. And we think that because there isn't a big clog of cholesterol, and that it is possible that it would release like that, may be why SCAD heart attacks tend to be smaller than regular heart attacks, which you're not going to have any resolution of the blockage early on. So we're looking to see how we might diagnose SCAD, either initially or follow up with CT. So we know we can miss, so CT has gotten better. You can imagine, everything, technology has gotten better. And so we also know that you have to look for different things on a CT. Our radiologists have to know. And CT is of a moving heart. So there's a lot of computer reconstruction of those images. So you can imagine that the arteries that are farther out toward the tip of the heart, which is not only squeezing but torquing, might be harder to see. But CT is actually getting pretty good at looking at those more proximal arteries where we can, if we know what we're looking for, we can try to see and diagnose it. It's also good early on if somebody's having a heart attack if we see no calcium and no plaque. Look a little harder to see if somebody is, maybe there's a dissection. The dissection is kind of hard to see, and the plaque is pretty easy to see. So what was happening is people said, don't see plaque, must not be a heart attack. We know better. So we were missing them, but we wanted to see what are the signs that we can tell radiologists. Because a lot of these are done in the emergency department. And so what we found was, and you don't need to look at this, but what we found is that there were some signs. So if we can educate our cardiac radiologists to what they should be looking for, we might get a better yield on this. And CT may be a nice technique for evaluating chest pain after. It's one that we already are using, evaluating chest pain that occurs after SCAD. A couple months later, somebody comes in rather than doing a coronary angiogram. And so an actual dissection could be visualized in only about 14%, but sometimes all of these other things put together will help you with a clue. So we're not going to be, with current CTs, able to depend upon them. And this is just some other imaging that is looking at how we might use the CT and some images of dissections. Also looking for how can we maybe use cardiac MRI. Does cardiac MRI look different? We're using cardiac MRI a lot more for a lot of things, for cardiac disease, for ischemic heart disease, for heart attack, for pericarditis, for myocarditis. And it can be very useful to look at certain patterns on MRI to say that was, because young women having heart attacks isn't common, and they also get myocarditis, and that looks different on an MRI. So we find it kind of useful if somebody, and you can have an elevated troponin for myocarditis too. So looking at what is the characteristics of MRI, and so we're trying to do that. We've got some publications there. Looks more like a heart attack than myocarditis, but it doesn't look exactly like some of the heart attacks that we would see with atherosclerosis. So again, I don't read cardiac MRIs, and that's why we have this big team of radiologists and other cardiac specialists that can pull us along. A number of you have expressed
interest and concern because certainly all heart attack patients, cardiac patients, have a higher level of anxiety and depression. Women under the age of 60 after a heart attack have the highest risk, so who are most SCAD patients, right? So it's a group with a higher than average risk of developing anxiety and or depression after a heart attack, all comers. And so one, recognizing it, making sure that we address it, treating it appropriately, and making sure that cardiac rehabilitation is part of the healing because that's part of it. And so one of the things I had actually just observed in caring for lots of SCAD patients is almost classic descriptions of like flashback PTSD, where there were certain triggers that would bring them, and it sort of, well, just like sounds like. So there are measures, and we didn't in that first questionnaire that we sent that is part of the core, we did not actually have anything specific for PTSD. We did for anxiety and depression. So some of you may recall about a year ago we sent out some updating of the anxiety and depression questionnaires as well as some PTSD. This is one of our medical students. She worked on that project. We submitted the manuscript. We got it back with a revised and an invitation to resubmit just on my trip out here. So she'll be working on that. So that should be out in the literature. Hopefully we can address all of the reviewers, but it has been presented as a poster. So what we found was we asked people about traumatic events. And because we know that trauma is something that is associated with adverse health and actually adverse cardiovascular health. And although the level of PTSD was mild in most, 11% had at least moderate PTSD. We also looked at anxiety and depression. So it was greater than moderate in a substantial minority of individuals. So I think what that tells us is this is essentially, if not, it might be untreated, unrecognized. Maybe the patient hasn't talked to their doctor about it, or it's insufficiently treated, or it's whatever. But I would just say that this is such an important part of healing and well-being. And cardiologists do walk a fine line in talking about this, because I've developed a bit of a, because I feel very strongly about the brain-heart connection. But I have heard my cardiology colleagues say, even though I know she is depressed and I really want her to get help, the minute I started talking about that, she told me, oh, you think it's all in my head. And I think the one thing I tell patients is, it's not all in your head, and that may or may not, I'm not saying that there is a lot of, it's just anxiety. There's a lot of people who are having heart attacks that have been told that's anxiety or a panic attack. That said, I don't want to underestimate the importance of addressing that, because you cannot be fully well if you are not mentally well. And that's actually something much harder than healing a heart. So of the ones that had PTSD, it tended to be the younger folks, and they did have a lower quality of life as opposed to that. I don't like to talk about sudden cardiac death in a room full of patients, but we also know that all heart attacks can present with a sudden arrhythmia, maybe with chest pain, maybe at not. We know that that is a certain number of SCADs do. And so we have one of our cardiology colleagues, Colleen Lane, that was first author on this poster, where she looked at sudden cardiac death was the presenting symptom for about 10% of SCAD patients in our series. That meant that they had a cardiac arrest at some point during that. The vast majority never have a recurrence. And that's about 10%. So it's really unlikely. The reason this kind of research is important is it is our perception that perhaps too many women who have had SCAD, men perhaps too, are getting implantable defibrillators that may not need them. Because the guidelines for implanting a defibrillator, if you have a sudden cardiac arrest while you're having a heart attack, unless you have severe heart dysfunction, you don't need a defibrillator. But what we're seeing is people are looking at this young woman and they're really scared that, ooh, they're scary. So it's sometimes maybe the doctor's treating themselves more. And so we like to get more data around this, make sure that everyone gets a defibrillator that should get one. But defibrillators are not no risk. You get an infection, there is a huge psychological burden on having a defibrillator as well, and particularly if it goes off inappropriately.
So some of the things that we are working with, we're looking at the angiograms in a really close way. We're coding them all, looking at tortuosity, seeing if there's anything within the angiogram. We're being very encouraged. We have a lot of colleagues. I am not an AI expert, but we have a lot of colleagues at Mayo who, one, are, and two, are encouraging us and connected us with some resources to see how we might apply AI to a rare disease like SCAD. Maybe it's with the angiogram data. Maybe it's with the crowdsourced data that we have of over 1,000 people, and looking how we might be able to look at that. So this is just, I'm not going to talk about every single one of these, but they're all topics of high interest that we have either a medical student or a medical resident or a cardiologist who's looking at the data in such a way. The moving picture up there, some of you who've been to Mayo in the past year might have been asked to participate in an echo study that Dr. Fleet is doing as part of her research. And this, we hope, may help us understand what differences there are and why women continue to have chest pain after SCAD. Because it's so common, and it's much more common than it is after a regular heart attack. And we think it might be from the microvascular components, either coronary vasospasm or the very tiny blood vessels that are ones we can't see on an angiogram, but certain techniques using echo with contrast can give us a better idea about that. So I'll talk a little bit now about this is just more, so that's about the AI. So we're doing lots of stuff. So I'm going to speak, I am not Dr. Olson. These are his slides, and I will not answer really detailed questions about how he does his work. However, we're excited about the work that he's able to do. You know, when we started this, we were collecting DNA from patients and their parents. That was our IRB protocol, because we thought, well, someday we'll get enough patients that we can do whole exome sequencing. So whole exome sequencing is where we take every gene in an individual and we look for any, we map the whole genome. It's very expensive. We did do, early on, this is about 5 or 6 years ago, about 78 samples. So this was about 27 families and so a patient and their parents, one who had a family member affected. And the main thing I can tell you is, one, there's no SCAD gene. There's not a single SCAD gene, because that was a good enough study to say there's not going to be one thing that we will come up with. Because there were what we call candidate genes. That means a gene that was present in both the parents and the offspring, so a family of genes, that was also a gene that can affect the blood vessels, the arteries. Those candidate genes were different for each family. So again, important to know, but not a straight path to genetics and understanding this condition. So once we started getting close to 500 participants, we realized, you know, we never dreamed we would have enough to do genome-wide association tests, which is a different way. That's where you take the DNA and you compare it to a cohort that might be a normal group of age-matched and gender-matched individuals. And so that's the work that we've been doing more over the past year. And I say we collectively, it really is Dr. Olson and his team, and actually a PhD student who has done the whole PhD project on this. So the good news is, among those patients who participate in the research at all, 83% have given us our DNA. So a very high participation rate. If you think you haven't given your DNA and you want to, we're happy to take it. We've actually slowed down on taking parent data because we actually have enough of patient data, and we're being selective about that. So we're not asking everyone to contact their parents at this time. So as of, I think this was late August, we've got over 1,000 who are part of this, and we've got almost 1,000 that we've got the DNA. It's important because we're keeping segregated out those with recurrent and pregnancy associated. And then 175 where we've got all three. We've got both parents and the subject, and 12 familial SCAD, where we had more than one family member with confirmed SCAD by angiogram. They're from all over the world. And so this is how we look at that. Remember I said there's not a single SCAD gene. For a condition like Marfan syndrome, and that's where people are very tall, they have a very weak aorta, they often have eye problems and limb problems. They look different, so we suspect Marfan's, and we do a gene test, and we get a gene. And often it has family members. And so there is a gene that we can test. There's many conditions, cystic fibrosis, for instance, where there's a gene that we can test. Coronary artery disease, we know there's lots of risk factors, including family history, but there's not a single gene that tells you get plaque versus not plaque. There's multiple genes that have been identified that increase one's risk for developing plaque. We are thinking that SCAD is going to be like that. It's going to be more that way, maybe a little bit in the middle. There may be some marker genes that are more important. So I told you we're doing the whole genome sequencing and genome-wide association. Basically, he puts it in his magic machine. It takes many hours. And so the first big publication that came out was this one, which we did with England and Australia and New York. So I think it's important that we have lots of different types of patients. And one of the challenges in this paper is there was very little diversity, very high numbers of women, and mainly white women. And we know that SCAD affects all races and ethnicities, and so that is one thing that I think we really, for a variety of reasons, but if you are spreading the word in diverse communities, making sure that they understand that we are really excited to have them as part of research as well. But what did we find? A lot of authors there. So we found on this particular locus of a gene that SCAD patients were much more likely to have this A allele, okay? And that people with coronary artery disease were more likely to have the G allele. And that actually it was protective in the SCAD patients against atherosclerosis. So it might not just be, oh, SCAD patients don't have risk factors. It actually may be that the gene that may increase the risk of SCAD actually decreases the risk of atherosclerosis. This has been shown in one other study that we replicated it. And so not that this means we run out of change treatment, but it's a clue to advance things. And also, you know, I tell my SCAD patients now, because I had no reason to believe that they were at lower risk for atherosclerosis, so I'm going to treat all your risk factors for atherosclerosis because you're going to live through this old enough to have an atherosclerotic heart attack. It may be that they are at lower risk for that. If that's not confirmed, we'll have to do some other studies. So this is another study. This is under review. We received it back. It is likely to be published. First author is this PhD student. And so we did the whole genome sequencing in those folks. And the short answer is we also confirmed that differences in genes that it appears that SCAD, the things that increase the risk of SCAD, may actually lessen the risk of atherosclerosis. So this is a list of current folks, not even a complete list, who are working on SCAD at Mayo Clinic. It's updated from the little picture book that you've got in the other, and Camille Turley is the one who's really devoted to her. And I also think it's cool because she's a non-traditional, I mean, she has a kid, she's in college, and she's a PhD student, and so is really doing a lot of this work, and has, she and her family, they came to the Minnesota and the Chicago law. So I will stop here and take any questions or comments about this research or about some practice. Got one there.
Yes, I just have a question about the ongoing chest pain that a lot of us experience, and I've had a couple episodes that literally lasted weeks and ended up being nothing. So my question is, why can't you just get a component test at a lab so you don't have to go through this exercise? Should I go to the ER? Should I not? And my one cardiologist told me, well, because you've got the information and you're positive, what would you do with it? Well, then you go to the hospital. You take care of it.
Yeah, I think that's a tough question. So one, chest pain after SCAD is really, really common. Sometimes it's clearly non-cardiac. It is, people are hyper aware of what's going on in their bodies, and what used to just shrug off as kind of a twinge is now something, I just had a heart attack, so I need to get it. So early on, that's a lot of it, and it's really important that you get it checked out because then you get that positive reinforcement that, all right, somebody can run the mic around for,
Yeah.
Great, and then I don't have to repeat the
That's
question.
not a hard thing.
Yeah, so you get that, and sometimes, and that's why, you know, often we have people who have 2 or 3 ER visits in the first 2 or 3 months, and then it goes down because they know, okay, I know that's not hard. I'm confident that's not hard. And that's why cardiac rehab. That said, and I'm going to come around to why I don't think that on-demand troponins is probably a good idea. There's some reasons. I think the other is that there are clearly chest pain that might be a stent restenosis, and you need, it may not be a heart attack, but you need a stress test or something like that to your doctor to rule that out. And then there's a whole large group of patients after SCAD, which we don't see after a regular atherosclerotic, is it's cardiac pain. It's relieved with nitroglycerin consistently, right? And it doesn't necessarily come on with exercise. It comes on in the middle of the night. It comes on with mental stress. And once we know that there isn't a fixed blockage, I think very active medical management that cardiologists may not be used to doing by using things that relax the blood vessels and other things, and to decrease the frequency of the chest pain. And I've heard women say, and it's usually women who say this, well, is the chest pain going to kill me because I don't want to take any more medications? And I said, well, probably not. But let's frame this differently. One, it's sending you to the hospital and impeding your quality of life. And when you're having chest pain, that means your heart muscle is not getting an adequate blood supply. And it's likely that it will improve in 15 minutes, right, if that's your pattern. So let's get it to the point where you're not having this intrusive symptom. There will always be the occasional time that, even despite optimal medical management, you know, you've been great for 3 months and haven't had a chest pain or just normal, that you have then a longer or more severe or more active. And I personally think you need to be checked out. I know you go through the exercise because you know you walk in that ED and you're there for 24 hours. And so getting you to the point where you know when you need to go and don't go, I would just say it's better safe than sorry. And I don't think because if you're having a heart attack and that troponin that you get done as an outpatient is positive, remember 10% of SCADs present as sudden cardiac death. And that's not when you want to be driving back to the hospital because, oh, you report to the emergency department, oh, why are you here? I had chest pain and a positive troponin. I already know that, so I'm having a heart attack. So I think it's complicated because I know exactly your question. This is one of the toughest judgment calls that post-heart attack patients, and particularly SCAD patients, have to make, and they make it very frequently. But I do think if you are not feeling right, and that you should go. But I also would say you should not settle with having frequent chest pain. There are treatments for it, and there are evaluations for it, and your cardiologist should take it seriously. I'll let you decide who you get mine.
What tools are available for doctors? I mean, I had my SCAD 3 months ago. The doctor calls me once every few weeks. How you doing? Which is sweet. She calls. And I said, don't I have an appointment? Can I come in? Or she said, well, do you feel like you need to? I said, no, I feel pretty good. And she said, okay, well, then I'll just call you again in a few weeks. So I have no appointment. And what tools do they have?
Well, they have. I hope.
Well, that's what I'm doing.
Yes. So you don't need to be seeing her. I mean, if you're doing well, there is no value in you seeing her to say in person, I'm doing fine, because there isn't any additional testing or anything that needs to do. Nope. So it sounds like she's managing you if you're doing well. The fact she's calling you, most doctors don't. So that's amazing. So I guess what, but I get what your question is. Like, I just had this major life-changing thing. Should I be checking in more frequently?
I think it's a weird thing because there's like no tests. I mean,
no, and there wouldn't be a test for somebody who had a regular heart attack either. I mean, usually after rehab, we'll see somebody, we'll wrap things up, and we'll see somebody at 1 year. So if you want to say that's sort of the normal thing, and so if you are doing well, there isn't anything you would be doing differently, changing your medications or anything.
So right here,
it is a weird feeling, but I would say, yep.
So, we talk about anxiety. I think all of us would be not anxious at all if somebody said this will never happen to you again.
No, there would still be anxiety.
Yeah.
I'm just saying.
So, I guess the question would be, is there some sort of pattern that, and we all want to know if we're more susceptible than anybody else, if 70-80% of people have FMD, have you seen that people with FMD have more?
But we actually looked and could not confirm that. So I think the other question inherent in that would be, okay, is it like breast cancer that if I get 5 years out, am I home free? There's a number of conditions that the longer you go without an incidence or a recurrence, then the much lower risk. I think that's going to be an important question. I think we finally have enough people in our registry, we might be able to say yes or no. Obviously, it would be great if I could say I'm 10 years out, so I'm good. But we can't say that now, but I think that in our next analysis, we're going to be seeing if we have enough people and recurrences that we can put that together. So far, we have not identified any people risk factor for lower risk or higher risk. Unlike atherosclerosis, where you say if you're diabetic and you keep smoking and you do this, then those are higher risk, and those of you who don't do those things or take these medications are low risk. So I think the question you ask, because that is really what is most relevant to most people, is am I in that, I got a 50-50 chance of having it again. Well, maybe we scale back the exercise guidelines more for that individual, or we are much more, we say, yeah, you really should be on a beta blocker, even if it's making you feel icky. I would love to tell the woman who's got virtually no chance of having a recurrence that, go live your life, have a baby. If we could get there. So I do think that that's a very high priority, but we have not had the numbers to be able to do that. So we are looking at that now. In terms of the angiograms, the tortuosity, that study, and we're looking at doing all that laborious measurement of arteries on CAT, again, to look at that. What we found, and it wasn't that people with more tortuous arteries have recurrences, but where there was a recurrence, it happened in a more tortuous area of their arteries. So it wasn't so much that tortuosity, which 70% of SCAD patients tend to have, was a risk factor, but if somebody had a recurrence, that did to be perhaps a more vulnerable area of the artery. Is that differentiation?
Would that be because blood likes like a clean line? Would there be plaques sometimes in that area, or no?
Probably shear stress, which is a physics thing, a hydraulics thing, but the shear factor of blood going through an artery might be greater in those areas. That's a hypothesis. Okay, James.
All right, this is an online question. In December, had a bump in my cardiac enzymes. My doctor did not seem concerned and said it was probably my BP.
I think, so presumably this individual didn't have an angiogram. I think that would be, are we to believe this is somebody who had a SCAD, or you
Yes,
not?
she had a SCAD.
Okay,
Yes.
had a prior SCAD. Yes. So a bump in enzymes means there's been heart damage. And so there are other causes than a heart attack that can cause that. There's inflammation of the heart muscle. There is a thing called a type 2 myocardial infarction, and that is when there's no blockage, but it's something else, like somebody has a major hemorrhage and their hemoglobin's 4, and the heart muscle is not getting enough blood supply or something. High blood pressure would not be in general. So the answer to that question from whoever's watching is, I would not want to say that that was the cause. I think more investigation. But if the blood pressure was very high, it probably needed. Was it a SCAD? Who knows? Because it wasn't evaluated. Who's got the mic?
Right here, Carol.
Hi, thank you so much for the presentation. I just have a question. I saw that Dr. Tweet published something this year, and there's no abstract. It was the evidence on estrogen and progesterone in spontaneous coronary artery dissection. Could you tell me just briefly what that came up as?
Yeah, so the reason that didn't have an abstract is it was actually sort of an opinion piece, or it was a summary of the evidence as well as just talking about music. So in medical journals sometimes there's original science that we'll publish, and that's where there's generally an abstract. And then there's something sometimes some articles that we'll put together, there isn't quite enough, but this is coming together of experts in the field who will write about what's known and isn't known. And so what we did, and it was Dr. Tweet and me and Dr. Virginia Miller, who is actually a gastrobiologist, physiologist, who works in women's health and does hormone research on arteries at Mayo, and wrote this and sort of laid out a number of the potential hypotheses, what we know and don't know. So that was what that was.
No findings.
No specific findings. It was a summary of findings from both us and other researchers. So Mike.
Hi, I am Gigi. Thank you for doing this. I had my SCAD heart attack and cardiac arrest March last year. It happened in the ambulance, so it was easy for everybody to know exactly what was going on. And I also came back on my own. But it happened in a loop. I have like an extra loop, and that thin part in my loop is where the SCAD happened. I spent 8 days in the ICU. By the second day, I honestly felt pretty good. I was like, I don't think I should be here. But they kept me just checking and making sure that they put me this study that they put this radioactive thing in my veins, and showed me, 2 days later again the machine, all this stuff. They also did last year, like in December, to check FMD, and that's negative. I'm supposed to be fine, but I have an aneurysm. That's why they stop it. Talking to Jody, she says some people, they just know. I didn't see her, so I'm guessing they know about FMD, how to check. How's it, should I have somebody send it to you guys and you guys can check it?
So let's just talk about FMD diagnosis. Thank you for the question, because so first of all, we did come out in the consensus statement that SCAD patients should have a screen for, to frame it for those of you who either because their doctor says you don't need it or your insurance company doesn't need it, I think it is important to frame it. A simple diagnosis of FMD, because I've heard cardiologists say, well, it won't make any difference, because so why bother? It'll just make you worry. I think that's patronizing myself, but the point is, having mild FMD, which is what most SCAD patients, if they have it, is, it probably won't change treatment. It will mean we maybe manage the blood pressure a little more aggressively. What we're looking for is complications from FMD that might require treatment. Because if we say that 70+% of patients who have SCAD probably have FMD, and that known complications from the FMD are aneurysms and dissections, and in particular brain aneurysms, then we should know about those because they might warrant treatment, particularly right now, or we might want to watch them over time to make sure they don't grow. So that's sort of that rationale for finding it. So if your doctor's found that you had an aneurysm, and are presumably either following it or have treated it, that actually is probably satisfactory, because that's what clinically you needed, and that's what we're recommending. Now, fibromuscular dysplasia can be tough to diagnose, so the second part of your question is, can I be confident that you do not have fibromuscular dysplasia? And the answer would be no, because depending on the technique that they use to diagnose it, and or we may or may not be able to know with additional scanning. So I would separate the two questions, because I think that there have been some people that are scanned. Well, I know, actually, I absolutely know that have been scanned, and we saw no FMD who have FMD. And the reason we know that is maybe they have such subtle FMD that the limits of the technique of our tests. CT is better than MR. Ultrasound should not be used to diagnose it. I still see lots of people trying to say, oh, they had a clear renal artery ultrasound. I guess they don't have FMD. That's insufficient. And people can have it, so they can have it so mild that it's missed, but they also can have it in a part of the body that we don't scan. So we have had several where they had FMD in their arm or their leg. Now that doesn't mean that we should scan a whole body. Remember, we're looking for serious complications. That would be an aneurysm or dissection somewhere here. So there's probably some people who are walking around who had a clean scan that have FMD. I know several. So I no longer say, good news, your scan was negative. I say, you have no evidence of complications for FMD. You have no FMD that we can see. And Right now, we don't need to do anything. But I don't actually say because of those rare exceptions, you absolutely don't have FMD. And I know that's a long way of saying it, but FMD is also an area of very hot research, and I think it's been very fun for the FMD researchers who have felt like they were doing this rare disease research off in the boonies that nobody paid attention, and now they've embraced SCAD, and SCAD, you know, and I never thought I'd be an FMD expert, right? I had some vascular docs at Mayo that were the FMD experts. So I think that that has rejuvenated both fields of research, honestly, and allowed us to do that. So I hope that sort of both answers your questions and kind of frames the idea is, as you're looking at this, what we're really looking at is, do you have complications related? Do you have a brain aneurysm? Because we make that, and we honestly, it's very rare that we find a treatable vascular problem, one that needs to be. Most of the time, it's just, yeah, we should check another scan in 6 months or a year, and if it's the same, we're not, you know, we're done. We've had a couple of brain aneurysms that have required treatment. About 1,000. That's the mic.
I have two questions that are kind of related. One is there a guideline for SCAD survivors regarding suggested exercises, and perhaps a PDF version that can be shared? And the other one is, how soon after a SCAD should you do cardiac rehab?
So the answer to the first question is we've actually got a paper that we wrote that will be published, so hopefully a PDF-able in the near term. This lady had her hand up for a long time.
Oh, which lady? Sorry.
Yes. So regarding exercise, so hopefully in the book that you got today, there is something that we have put together, which is kind of our best, but I will summarize that. So because some SCADs have been associated with extremes of physical activity, probably more commonly in men than in women, we recommend avoiding those extremes of activity. So in terms of aerobic exercise, so not exercising to exhaustion, not doing extreme contact sports or competitive sports, and not exercising in extremes of temperature, cold or hot. So those things that would make you exercise to exhaustion. So can I run a 5K or a 10K? Of course. What we prefer you didn't do is make it a personal best time in racing a 5K or a 10K, or today like an 8K, or whatever it was. whatever I yeah, I got my exercise. I burned a few extra calories. I had 2 pieces of pizza for it.
We only paid for 5K.
I know, we paid for a 5K. But I think that, so from the aerobic exercise, I do not give heart rate limits. Those are arbitrary and inappropriate often for younger people whose heart rate normally goes up and they're fine with it. And it's different whether you're on a beta blocker or not. So it's how you feel. You should be exercising moderately hard or even hard, but not too extreme, not extremely hard. So for weightlifting, and this means both for exercise but around the house, is don't lift anything that requires you to strain or do a Valsalva maneuver. Valsalva is when you hold your breath and bear down, like that, when you're trying to lift, lifting perhaps a sofa. So furniture moving, if that was your profession, is probably one that you might want to reconsider. Moving heavy rocks in the yard and carrying a suitcase that weighs more than 50 pounds. How I describe how you might, I also don't give a weight limit for that because it's different from every person. So for me, I'm reasonably fit, but I'm not super strong. I can lift a 40-pound bag of softener salt with a fair amount of effort, but not Valsalva if I'm paying attention. So if I had SCAD, I'd keep it under 35 probably, right? Because I sometimes, if I'm sort of yanking, for you it might be 20 pounds, it might be 50 pounds. But if you have to really strain to lift it, you should have somebody else doing it.
Yes, thank you for all the information. I just want to be clear. You did suggest if you have reoccurring pain, you go into the hospital. Should you also take your nitroglycerin and aspirin and treat it as a typical heart attack?
So yes. So yes to both. So, and I want to say that every twinge of pain, I think that is very individual. Certainly most people get to a point where it is either of a severity, a similarity to a prior heart attack pain. It's not going away with the usual things that it would go away with. You know, you try some Tums and you say, you know what? And if nitro makes it go away and makes it go away for good, that would depend on if this is the first time it had ever happened versus about once a month I need nitro. Right? I have patients that they need nitro every once in a while, and they don't go to the ED every time they have a twinge of chest pain. So that's a very, but if you are having chest pain that is worrisome enough, prolonged enough, and if you've been prescribed nitro, you definitely should take it. That's what it was given to you for. Whether you then go to the hospital again depends on, do I take nitro once a week? And that's just my pattern of pain, whereas this is really unusual. I haven't had chest pain in 2 years. Yeah, take the nitro on that. Yeah.
Hi. What have we learned about stress and SCAD? I know we talked about that several years ago, having just been released from a very stressful job for 4 years where the chest pain came back, I was on maximum medication and really was fearful of a recurrence. So as I'm recreating my new normal version, I don't know what, 3, 4, something like that. How much does stress play into having a healthy heart?
So that's a great question, and there's not a lot of data specific to SCAD, but there are gender differences in the way the heart responds to mental stress. So there's some great studies that are being done at Emory by a colleague of mine who's been interested in mental stress and heart disease. And so her stressors in the lab are mental arithmetic, which is or giving a talk in front of people dressed in white coats. So they're given a topic and they have to give so it's like real, just acute stress. And some amazing work is coming out of this because she's measuring all sorts of things. And what we know is women are much more likely to have mental stress-induced angina than men. Men are much more likely to have it with exertion. And again, these are not SCAD patients, but what we see is the population who is getting SCAD is also one who is more likely, much more susceptible to stress-induced illness, and particularly chest pain. So, and it's probably microvascular dysfunction that is induced by mental stress. And we've actually known that mental stress is more likely to occur in women versus men for probably 20 years. And since, this goes back to my old days of just gender medicine, is if the way that you diagnose heart disease is putting somebody in a stress test, and women only get chest pain when they have to do mental arithmetic or get up in front of strangers, doctors, and give a talk, their stress test is going to be normal, so they were just told you don't have heart disease, right? So I think stress is really important both to manage stress in whatever ways it is, and for doctors to recommend that maybe you need anti-anginal medication for stress-induced chest pain, just as you do from blockage-induced chest pain and exercise-induced. And I think it gets undertreated because what I have seen happening is you come in with chest pain. It's called atypical because you don't get it when you exercise, and it's probably very typical for others. I hate the word atypical because typical is designed for a 70-kilo man. And which there's lots of reasons that shouldn't, in lots of diseases, that shouldn't be the case. So, but if you are getting mental stress-induced chest pain, I think there's 2 guiding principles. One is make sure it isn't a fixed blockage. So I usually would still do a stress test or a CT coronary angiogram if it was new. 2, look at managing stress to the best way we can, and whether that's mind-body techniques, whether it's counseling, whether it's medication. And then 3, using appropriate, unroll it. I don't want to break it up here. And 3, then using medicine, because often this type of chest pain responds to long-acting nitrates and calcium channel blockers, just like angina that people get when they walk up a hill. So I think it's undertreated and under-recognized is a big thing, but I like to charge women to make good choices because maybe this was a sign that that job that you had or that situation that you had isn't worth it your health, and don't put yourself back into it as you're regretting your life.
Thank you.
Yeah.
I was curious, you were mentioning earlier about the tear in the artery and it dissecting and relieving the pressure and going away. Whenever a occurrence like that happens, does the troponin level always increase?
That's a really great question, because I have, just because I've seen so many SCAD patients and heard so many stories, I've had patients who have said, they get diagnosed with SCAD appropriately and everything, and they said, you know, 2 years ago, I had the exact same thing, and I didn't go in. But it was the exact same thing. And so doing, you know, your troponins might have been elevated at that time. If you have the pain and there wasn't any blockage or dead heart muscles, troponin leaks from dying heart muscle cells. So if you had a tear that was painful, but it did not result in enough blockage even transiently, so theoretically you could have a dissection without a troponin bump. We have one in our registry that we've called unstable angina because it was pretty typical pain. So one or two, but those also could be people where we missed the troponin. They came in later, the troponin bump maybe was 3 days before and ended. But I think theoretically it could, and we think that that would be really rare. The vast majority of people have an elevated troponin, which is why it's a good test.
I just wondered because when I went in originally, the first time I had pain, they said I had a false positive troponin level.
There's no such thing.
And then they sent me home. So when I was out hiking the mountain and I had the exact same pain, I doubted my judgment.
Yeah. And I am sorry that some clinician made you doubt yourself, because there's no such thing as a false positive.
Any more questions? Oh, one more. Yeah, because then we're going to...
And they would have never, just like Christine Shockey, and I showed the slide, they would have never sent a man out with an elevated. Just, they'll send somebody who looks like you. And that's got to change.
Just a quick question about one of the slides you had up, when you talked about somebody's hemodynamically stable. You're doing the angiogram. I was given morphine, so that took my pain away. And for the most part, I went from like 8 to 1. Of course, it was very uncomfortable, but the chest pain wasn't there. So I was given a stent, and they thought I was having a vasospasm. They had never seen SCAD, I don't think, which is why I got the stent. How do they know if you're hemodynamically stable at the time that you're going through this? If pain is not an indicator any longer.
So pain has nothing to do with hemodynamics. So we go by symptoms. So if somebody has settled down with symptoms. In hemodynamics, what that means is heart rate and blood pressure. So somebody's in shock who has slow flow, we're going to open up that flow. That's what the hemodynamics is. It's heart rate and blood pressure for the most part.
Any more questions? You have anything else you want to?
No, but just thank you.
Yay.